Okay, I'm reminding you again. This is Julian. She is 3 years old. She has problem in both upper limb and lower limb and walking difficulty for last 6 months. And
Okay.
mother came with the abnormal gait. Okay, please do the related examination and Piggles. This is your command,
Okay.
and I am putting your time now. You will start from the beginning. Say, start.
Okay. So I'm going to wash my hand, introduce myself, take permission to examine the girl, and build some rapport.
Okay. Yes, permission
Okay.
granted.
Okay. So how is she talking to me? How is
Talking
the
normal.
mentation and speech?
Mentation and speech normal.
Is there anything in the surrounding?
Nothing in the surrounding.
Okay. So she looks well to me,
Well
alert.
alert. Well alert.
Okay. And what about her growth? I would like to plot her on centile, height,
Yes.
weight.
Chart I will not tell you, but short stature.
Okay. So then I will like to see her facial features. Is there any atypical? I can see the broad forehead, and I cannot see and the broad short nose. There is a triangular chin. I don't know about the ears. Is there anything
Ears
specific?
are normal. Ears are normal, and broad forehead, yes, present. Nothing significant.
Okay. Then is there any squint, any support in the
No.
form of the eyeglasses in the surrounding and thing?
No.
Okay. Then I'm going to start the Piggles to. I'll ask her to walk for me.
Yeah, he is
How's
walking
she
for
walking?
you. How he is walking in a waddling gait.
Okay, then I would like to I would like to ask to bend down from the back. I can see that there is the asymmetry of the scapulae and the asymmetry of both the lower limb and hands. So I would ask her to bend down to check for the scoliosis.
She cannot touch the. You have to give pause for examiner. Okay, she cannot touch the floor. Number one, when she touch the floor, the spine is same. Okay,
Okay.
scoliosis does not disappear.
Okay, what about the range of movement? Is she's having difficulty?
No difficulty.
Okay, then I would like to ask her to just do the close inspection from 3 views of the lower limb to check for any scar.
No scar.
I would also like to check the scar under the pants, under the clothes. Is there any?
No scar and no need to see the under the cloth.
Okay. Then I can see the deformity of both the lower limbs and like some contracture at the knee also. So then I would like to do the movements. Um, I will ask her to just sit down on the couch to check
Okay.
for the 6 movements at the hip joint. These are the flexion, extension, internal, external rotation.
There is no problem. No problem in the hip movement.
Okay, then I would like to check the movement of the knee, flexion, extension.
No problem. No problem. Normal.
And then at the ankle, the flexion, dorsiflexion, plantar flexion, eversion, inversion.
Normal.
Both sides are normal.
Yes, both sides are
Then
normal.
I would like to check the hand. Also, check the hands to start from the hand. Is there any scar?
No scar.
Okay. Is there any deformity of the hands? I can see the elbows are a bit different,
Yes.
especially the left one.
Yes.
Okay. So I would like to ask her to just do the movements of the shoulder joint.
Full range
To
of
do the
movement.
abduction adduction.
Full.
Full.
And
Then
normal.
okay.
Yes.
Okay, then movements at the elbow, flexion, extension,
Normal.
and then at the do the prayer sign and the anti-prayer sign,
Normal.
and then 3 fingers in the mouth.
Normal.
Okay, then I'll at the same time I would like to check the beaten score. To check the little finger to little finger hyperextension and thumb to
No, there
forearm.
is no sign of hyperextension.
Okay, then I would like to check the movements of the spine, the cervical spine to do the flexion, extension, and lateral rotation.
All are normal.
All 6 movements are normal. Then I
Normal.
would like to check the movements at the thoracic spine, but I would fix the thoracic spine first from both of my hand, or I'll ask her to sit down to do
Okay,
the
normal.
rotation bilaterally.
Yeah, normal.
And then the lateral flexion, both sides.
Normal.
Okay, and then the flexion.
Normal.
Okay, then I would like to start the general examination by checking her clubbing. Is there any clubbing?
You have 1 minute left, okay? 5 minutes now. No,
Okay.
there is no clubbing, nothing
Okay.
in the palm.
Okay. How is the pulse?
Pulse normal, regular.
Okay. Is there any swelling I can feel?
Yes, you can feel there is swelling in the wrist joint and elbow joint.
Okay. So then I would like to check the dental crowding and the.
Yes, there is dental enamel hypoplasia.
Okay, and then chest for the ricketic rosary I can appreciate.
Yes,
Is it
there
there?
is rickettity, yes, present.
Okay, is there any alopecia? I cannot
Yes, there is
appreciate.
alopecia. There is alopecia.
Where? Any specific area or generalized?
Frontal balding, yes.
Okay, then is there any porta cat? I cannot visualize, but
No
is
porta
there?
cap, central line.
Okay, I would like to check the double malleoli sign.
Double malleoli present in the elbow joint. Yes, your time is finished, Dr. Bella. Present your case.
Okay, today I examined Juliana, 3-year-old girl. She looks well, obeying my command. There is in the P girls, there is no limitation of movement in any of the upper limb, lower limb, and the spine movement, but there is a frontal bossing, and there are the signs suggestive of the rickets in the form of the wrist widening and the genu and the I forgot the sign there is present in the wrist, which is then there is a dental crowding present, ricketic rosary is present, and double malleoli signs are also present, which is suggestive of rickets, which is type 2 rickets, vitamin D dependent rickets type 2, which is associated with alopecia.
Okay. What is the most common cause of ricket?
The most common cause of rickets is the nutritional deficiency.
What are the other differential diagnoses in this case?
Yes, the rickets can be secondary to so many other systemic diseases like the Fanconi syndrome and use of some drugs. And
for this baby, not
chronic
generalized.
rigidity.
For this baby, what is your differential?
I would like to keep the differentials of mucopolysaccharidosis, as there are so many bony deformities, and also the short stature.
Can it be a case of osteogenesis imperfecta?
Yes, it can be, because
I did not show you blue sclera. Okay.
Yes,
okay.
But it can.
So,
yes.
Okay. So ricket, right? You said it ricket. So
Yes.
in case of ricket, what are the other differential diagnoses? Different types of ricket can happen in this child.
Type 1 vitamin D dependent ricket, which is secondary to the enzyme deficiency, which is hydroxylase enzyme deficiency. The vitamin dependent type 2 ricket, which is we are suspecting in this case, which is secondary to the receptor insensitivity of the vitamin D activated form, which is also associated with alopecia, and the other forms associated with the hypophosphatemic rickets, in which there is a familial predisposition and the bony deformities like bowing of legs. The other one is nutritional deficiency, but the deformities and the severity is not this much as in our case. And also the other form is ricket secondary to the renal osteodystrophy, which is in case of CKD.
Okay, so I will tell you what point you missed in the general examination, but it's okay. So you said it is most commonly vitamin D dependent type 1 because there is alopecia, right? Okay.
No,
so
no, two. Type 2. Type 2 is associated with alopecia.
Okay, so what is the main differentiating point between type 1 and type 2?
Yes, the main differentiating point is the type 1 is responsive to the normal dose of the vitamin D, but type 2 is responsive to very, very high dose of the vitamin D because the receptors are not sensitive.
Receptors are resistant. Yeah.
Yes.
So, okay, so how will you investigate this child?
Yes, I will investigate by doing the bone biochemistry and the baseline workup, which include the CBC and the serum calcium, magnesium, vitamin D levels, alkaline phosphatase, PTH, urinary phosphate levels, and both the forms of the vitamin D. I will check, and I would do the imaging in the form of the X-ray, wrist, and X-ray wrist and the X-ray of the other long bones.
Okay. How will you manage this child?
Yes, I will manage this by giving the vitamin D supplements and STOS therapy, and then on maintenance therapy, um, vitamin D rich diet, sunlight exposure also, and
How many
uh,
days you will give vitamin D? How many days you will give vitamin D? Oral form or
for 3
give
months.
iron form?
I will give 3 months for 3 months, and I will recheck the levels.
You will recheck the level. Okay. Daily you
But
will
in
give
this
daily or
case,
you will
very
give?
high dose of the activated vitamin D3 is advised.
Achha, you will do daily or weekly or monthly?
There is a whole, like, I don't remember. I think initially first dose, then I don't
Okay,
remember
we'll
the.
check. We'll check. Okay, we will check. Okay, so Dr. Bella, 3 minutes has gone. Okay, so they will ask you hardly present your case. Okay, so how did
Yes.
you present your case? Just tell me again. Julian, her name is Julian. Again, tell me again. Present your case.
Okay, today I examined Julian, 3-year-old girl. She is well looking, talking to me. There is a frontal bossing, and she has multiple asymmetry at different bony levels and deformities in the upper limb and the lower limb and the protruded tummy. There is a waddling gait. There is a scoliosis, which is a structural scoliosis. The P-GALS is normal. There is no hypermobility on the restriction, but the signs suggestive of the rickets in the form of the wrist widening, dental enamel problem, and ricketic rosary, short stature, double malleoli sign, and bony deformities.
Yes, very good. Yeah, you did almost 98% complete. There are 2 or 3 minor mistakes. Like in the presentation, first time you said there is dental crowding, but actually I said you dental hypoplasia. So it was not crowding.
Yes,
Okay?
yes, I forgot that. Sorry.
Yeah, you slip of tongue. It's okay, slip of tongue. There were other features, Dr. Bella, like gait was waddling. Okay, you did not mention it. Gait was waddling. Then spine, there is scoliosis, you did not mention. Presentation, I'm
Yes.
talking about during presentation. During presentation, you did not mention about the spine. And one time you said left limb is more difficult than the right limb, the more deformity. That is also slip of tongue, because here you can see the right upper limb is more, right side is more affected. See the baby, right side is
Yes,
more
yes.
affected than the lower limb, than the upper left side. So these babies as a whole right-sided problem. Okay, but yes,
Okay.
overall generalized bony deformity. You can say generalized bony deformity in the form of, okay, in the form of bowing, anterior bowing, okay, and lateral bowing of both the upper limb and lower limb. There is double malleolus sign. There is widening of the wrist, widening of the ankle, widening of the wrist, ankle, and elbow, both, all widening. There is ricketic rosary. There is also pectus, what that, pectus carinatum,
Pectus
right?
carinatum.
Yes, that is Harrison sulcus, but you did not mention it. Harrison sulcus is also there.
Okay.
And you can see there is balding, frontal bending in the form of alopecia, and there is large head. You did not mention about large head. Okay. Yes,
Yes.
Jenudhara. Genu valgus deformity, genu varus deformity. Yes, you did not mention about the large head. You did not mention OFC. You did not plot it in chart. This child is below 5 year. Below 5 year child, we should plot it OFC in the chart. And this is a case of ricket. There will be, there can be, fontanelle can be palpable. Okay, and the hairs are see, very
Yes.
thin and fragile here, and also balding. Okay, and then depth, and then eye is important here. So you should ask me, although I covered, but you should ask me what is the eye. Okay, is there
Okay.
anything in the eye like corneal clouding, like blue sclera? I would say no. You got my point? So these are two important no. That is corneal clouding and blue sclera. No for what? One for bony
Okay.
deformity for osteogenesis imperfecta, another for Hurler-Hunter, right? So
Okay.
these are no. And then bony deformity, you will tell as a whole. Then you will start from the general, that the child is well looking, alert. There is no dysmorphic feature, no distress, no device, nothing in the surrounding. The child looks hyper, that the OFC, occipital frontal circumference, looks bigger, but I would like to measure and plot it in the chart. And looks box shaped head, looks box shaped head. And also dental, there is yes, I'm going. So dental, there is bony dental hypoplasia. And in the systemic examination, Dr. Bella, you could say that I would like to examine abdomen for hepatosplenomegaly for Hurler-Hunter. Okay.
Yes.
And also, I would like to check blood pressure. Why? In case of renal ricket. Okay.
Okay.
You did not mention jaundice. I told you the command is MSK plus general. So you have to mention jaundice. Why? For liver cause of ricket, right? And there can be skin changes like coarse facial feature, bushy eyebrow. These are absent. So there is no skin change in this child. Also, there can be petechiae purpura. Why? In ricket, there is platelet dysfunction. So the child can have thin skin, petechiae purpura. Okay. And then you did not mention scoliosis in the back. Yes, that is very important. Scapula, there is also some change in the left side. Right side. Right side as a whole, right side has problem. Scapula also malformed. Okay. And regarding systemic examination, you did not mention developmental assessment. This child could be a case of delayed development. Why? Because of mucopolysaccharidosis, because of ricket. So in the systemic examination, you should mention abdomen, you should mention blood pressure, you should mention developmental assessment. Okay, as there was waddling gait. What you could do, Dr. Bella, what are the differential diagrams? Gower sign, yes. Although I don't agree, this is a case of Duchenne, or because it is a female child. It cannot be Duchenne, it cannot be Becker. But in the ricket, there is Gower sign positive. Why? Why?
Proximal, because of the
myopathy. Yes. And hypocalcemic tetany, yes, signs of hypocalcemia, Dr. Kohli said. So if you do the blood pressure, you will check the signs of tetany, calcium. This is called latent hypocalcemia. See, there is two kinds of hypocalcemia. One is prominent or overt, another is latent. Overt hypocalcemia, the patient will present with hoarseness of the voice or seizure disorder, okay, or ricket sign. These are the overt sign. But what are the latent sign? Latent sign is the what is that procedure? What is that procedure?
That Shostak signs.
Bostek sign, Bostek and Trozas sign, yes.
Trozer sign.
Bostek and Trozas sign, yes. So this Bostek and Trozas sign is important. Bostek sign and Troza. Troza means what? Tapping of the mandible. No. Bostek is the tapping of the mandible, right? Bostek. And Troza is the blood pressure. Right? Or ulta, I'm saying reverse.
We'll check.
You're right, Dr. Tamanna, you're right.
Okay, Vostek is the,
oh my God.
I remember like Vostek means tapping. So Vostek means tapping of the, in Bangla, I remember because
You remember like Chostek means chew or trouser means
yes, trouser, right. Chew, yes.
means
But
end.
Pankaj is right. Chew for Vostek, okay? Chew for Vostek. Because the spelling is CHOVS, Vostek. So you remember that chew for Vostek. Because the spelling starts from CHW, okay? So this is Vostek sign. And Troza means blood pressure. So this is important because these two signs will you will do when you do the blood pressure checking. You will do this Troza sign. And these two tests are indicating of latent hypocalcemia, because hypocalcemia is a prominent feature of ricket. Okay. So any other systemic feature, guys? Any other? I said development. I said abdomen. I said neurological assessment, because there is myopathic gait. So you should rule out why there is myopathic gait. And I said blood pressure. I said hypocalcemia. I said skin. Skin is important here. So any other systemic? I don't think so. Any other systemic? I cannot remember.
Okay, so if I revise again, you said that about the blood pressure,
Blood pressure, then abdomen.
blood pressure, abdomen.
Yes.
And
then
skin.
Skin. Yes. Then
skin for what?
Skin for thinning of the skin, and Pitiki purpura, because there is platelet dysfunction in the ricket.
Okay, okay. Okay, so blood pressure, abdomen, skin.
Dr. Bella, I'm your examiner,
yes,
and
yes.
my command is that tell me the findings of these pictures.
Okay.
Positive findings.
So I start from the head. There is a frontal bossing, and there is a triangular chin, and also there is a asymmetry of the two half of the body, multiple prominence joint, widening of the wrist, widening of the elbow, and on the right side there is the bowing of the forearm also. In the chest there is a prominent rib marking. There is a ricketic rosary, more pronounced I can appreciate on the right side. There is protruded belly. In the lower limbs, the genu valgum, both the knees are touching, and also the both legs are deformed. There is a pes planus, flat feet. From the back side, the hairline is normal. There is asymmetry of the scapula, and also the spine is a bit curved. There is a asymmetry of the body parts. The right side, like the right arm and the right legs are bow. They are showing bowing. And from the back side, there is no genu valgum.
Okay. Okay, yeah, that's very good. Yeah, that's very good. Only one or two things I would like to add. Number one is if you see the arm to trunk space. So the arm to trunk space is more on the right side as compared to that on the left side, which is going in favor of most likely scoliosis. Okay. The second thing is if you see the right Achilles tendon, there is some strip over it. So maybe this girl, she is wearing some sort of splint or something in her shoes inside, or maybe this is stabilizing the Achilles. There is something white strip on the right Achilles. The other thing is about the scapula, which Dr. Tamanna rightly said, that there seems to be winging of right scapula or something like that, but the right scapula is not, in place with the left. So you would like to do which test for this? Do we make sure that this is winging of scapula or not? Which test you will do?
Pushing on the wall. Pushing on the
Yes, very good. You will ask the patient to push on the wall. So what will happen?
It will become more prominent, I think.
Yes, it will become
Push
more
on the wall.
prominent. Yes. And Dr. Tamanna asked you your differentials. There is one very good differential, that is hypophosphatemic rickets.
Yeah, she said vitamin D resistant. Yeah.
Okay, she said. So actually I joined a bit late, so that's why maybe I did not. So I think that was a very good case. What isn't it relevant that whenever you receive such case, I don't know, I joined a bit late, maybe you have done all that. But I think the most important thing is anthropometry,
Yes,
measurements.
yes.
Very
And she
important in
missed,
this case.
she missed many anthropometry. She missed upper segment, lower segment
Lower
ratio.
segment. In the end, I
Yeah,
will put,
very, very important. Very important.
should
She
I
missed
offer
leg
it in
length
the end?
discrepancy. She missed leg length discrepancy. Yeah, you did not even,
Yes,
you should tell this in the presentation that I did not do upper
yes.
segment ratio. I did not do leg length discrepancy. This I want to do because your time was finished. So you should tell the examiner that I did not do, but I want to do. Okay.
Even if you see that there is frontal bossing, so you means that the head size is a bit on the higher side. So you should also do OFC even in this case, and also the total length and even the weight. Okay, so because if there are rickets signs, so maybe this is a nutritional rickets. So even you need to do the weight as well, and you also need to look for other signs of vitamin deficiency. Maybe this is a case of cystic fibrosis. You
Yes.
asked very rightly about clubbing, so that was very much relevant. So you wanted to rule out cystic fibrosis, but still maybe, I mean, there are some fat soluble vitamin abnormalities like A, D, E, K, I mean, the other than D, the other 3, 4. So gait is very relevant in this case, because if you suspect that this is maybe chronic malabsorption, so maybe there is ataxic gait in that
Right.
case. I don't know, maybe you have
Vitamin E
asked about that.
deficiency, vitamin E deficiency. Now, Dr. Bella,
Yes,
when she
yes.
asked me what is the gait, I told him waddling gait. But then, Dr. Bella, you should check 2, 3 more types of gait. You know, hill walking, tiptoe walking, running.
Okay.
Yeah. Although you know this is a myopathic gait because waddling gait, you know. But even then, the child can have double pathology. So see hill walking, see tiptoe walking, see running. He can do running or no? Okay, these things are very important. And you said lastly the Gower sign. You said that Gower sign is very important in this child because there is myopathic gait. Okay, and you asked
Yes.
me what is the anthropometry. I said you height and weight, below height and weight, she is failure to thrive. I told you. But at that time, Dr. Bella, you should finish the measurement like I
Upper
want to
segment,
do
lower
lower
segment.
yes, and I want to check the leg length discrepancy because there is definitely leg length discrepancy. Now, Dr. Bella, tell me how you will measure upper segment, lower segment, and leg length to this child. To this child, I'm not
Yes,
taking general.
I will take the full
child.
height, standing height appropriately, and then I will take the sitting height, and then I will minus the full.
How you check sitting height? How you will check sitting height?
Yes, I will ask her to sit down on the floor with uncrossed legs, touching all the prominences like gluteus, shoulder to the wall, and then I take the sitting height, and then I minus this from the full height, total height. So I'll get the upper segment, lower segment.
She will sit in the floor, and you will measure the upper segment, or you will measure the lower segment. She will sit
Upper
on the
segment. I will measure the upper segment.
Okay, from the vertex, from the
vertex to
top
the
of the
gluteus, to the
to
floor,
the gluteus.
and all
Okay,
the prominences like the gluteus region should touching the wall.
okay, good.
Legs should be uncrossed.
Then you will minus from the total length to the upper segment, right? So the lower segment will be there. So tell me, this child, what do you think? What will be the upper segment, lower segment ratio? This child?
Yes, in this child, the upper segment will be smaller than the lower segment as there is a scoliosis.
But this child also has bowing of the anterior bowing
of the leg. So maybe normal, or maybe normal, maybe
because he has both upper segment deformity and lower segment deformity. So maybe at this child, tell me what is the normal upper segment, lower segment ratio at this child, 3 years old? What is the normal ratio?
Yes, it is 1.3 is to 1.
Okay, now 1.3. 1 is 7 year, okay? 1.3. So it is 1.3. That means upper segment is 1.3 times more than the lower segment, right?
Yes.
Upper segment is 1.3 times more than the lower segment. But this child, maybe we will get 1.3 or maybe we will get 1 because there is both upper segment and lower segment deformity. So both are equally short. Okay? But Okay, now finish. This is finished. Now tell me how you will measure leg length discrepancy. Definitely there is leg length discrepancy. See the shoulder. Shoulder are
Yes.
not in together, and see the hip joint are not like that. This child has tilted. So tell me
Yes.
what will be the what will be the leg length? How you will
Okay.
measure this?
So the leg length discrepancy measurement is true leg length or the like false. So the true one is from the anterior superior iliac spine to the medial malleolus.
But can you measure anterior superior iliac spine?
Superior iliac spine to the medial malleolus from both
To
sides.
the medial malleolus, can you measure? Because this child has severe deformity. How can you measure? The tape will be like that, like that, like that, like that, like that. You do want to do like that. There is
It's difficult.
severe
Yes.
bone
So
deformity.
I can take the from the pubic symphysis, but it is technically difficult.
True one, not
So I will
false
do the
one.
Galilee
True one,
sign. Mhm.
true one. Yeah, true
True one.
length. Yes.
But how to measure it from the pubic symphysis to the medial malleoli?
No, that is false one. I am saying you true one. True
Yes. Yes.
leg length discrepancy from the anterior superior iliac spine to the tibial tuberosity. From tibial tuberosity is which one? This one is the tibial tuberosity, right? From
Yes.
anterior superior spine to the tibial tuberosity, then from the tibial tuberosity to the medial malleolus.
Okay.
So this
Okay.
is the measurement for anterior bowing or for any
Leg length discrepancy.
deformity in the lower limb, because normally you will measure from anterior superior iliac spine directly to the medial malleolus, but here as there is bony deformity you cannot do that. So you have to do from anterior superior iliac spine to the pubic to the tubercle of the tibia, and then from the tibia to the medial malleolus. So you
Medial
will
malleolus.
combine two. So this is the left sided leg length. Similarly, you will do right-sided length, like from the anterior superior iliac spine to the tibial tuberosity, from the tibial tuberosity to the medial malleolus. So you will compare that it should be equal, right? Suppose it is 100, suppose it is 50 centimeter. 50 no, suppose it is 20 centimeter equal to 20 centimeter. But it can be unequal. Why? Why it can be unequal in this child?
Because of the bony
Yes, because of the bowing.
deformity.
Yes, and
Bowing.
see the bowing is not similar. You see, the right-sided bowing is more than the left-sided bowing. Another point, this child, you will tell the examiner, I want to measure the intercondylar and intermalleolar distance. Normally, intercondylar distance and intermalleolar distance is less than 10 centimeter, but here it is more than 10 centimeter because of the bowing. There is more than 10 centimeter. It is knee joint, okay, because there is bowing, but they touch the medial malleolus. Because why touching the medial malleolus? Because of this bowing, medial malleolus is touching with each other. And as Dr. Tahir said very rightly, that there must be some procedure done or something done in this child, or maybe this is just a this is just a design, I don't know, maybe the design of the shoe. So you should remove the shoe. Did you tell the patient, did you tell the mother or the examiner that we should remove the shoe, then I will talk about gait? You did not remove, Dr. Bella. In the exam hall also, you will forget to tell that. And Dr. Pankaj said 6 centimeter. I'm not sure, Dr. Pankaj. I'm not sure. 10 centimeter?
Yes,
It's
Dr.
7
Tamanna.
centimeter.
It's
Seven.
is 6 to 7. Yeah, it's 6 to 7.
Okay.
It's 7. If it is significant, then it is 7.
Okay.
And in the intermalleolar, medial malleoli, I think it is
Same.
I don't remember.
Same.
Same.
Yeah, 6. Yeah.
So 6 to 7 centimeter. Yes, I told 10. That is not centimeter. Actually, it is millimeter. Sorry. So actually 6 to 7 centimeter. Yes, centimeter distance. It is.
Okay.
It is
Dr. Tamanna, I will leave. So I'm
Okay,
sorry,
okay.
I have to go. Calling me.
No, it's okay. Dr. Tahir, your feedback, please. I finished.
Dr. Tar, can you repeat this measurement intermalleolus from where we will measure and what is the normal value?
This medial malleolus to medial malleolus, this is intermalleolar distance, and this knee joint, it is called intercondylar distance. both the knee joint and malleoli, if it is more than 6 centimeter, then it is pathological.
Okay, okay, thank you.
Yeah, Dr. Tahir, sorry, I stopped you because of these two measurements. Okay.
Yeah, I think Dr. Tamanna, actually I joined a little late because I came late from hospital. But I think whatever I have attended, such type of cases, I think they are very much tricky. Okay, because you have to do so many workouts. It's very difficult case. It's not easy, especially if you get the command of do the musculoskeletal examination.
But Dr. Bella
Because
finished. She finished this by very fast maneuver.
I mean, you can do it by either you should take it as a short stature even, because anthropometry is a key in this case. I think if I'm an examiner and I give this case to someone and he or she forgets anthropometry, I'll fail him definitely, because you don't know whether this is disproportionate, this is proportionate, because that will lead you to the diagnosis of once you put it in some criteria, this is proportionate or disproportionate. Now here this is rickets, all the signs, it's a florid rickets. So first thing is that I'll put this in a case of disproportionate short stature. Or even if I think that this is a case of dysplasia, skeletal dysplasia, still I have to put it in a disproportionate short stature.
Yes,
Okay.
you're right. It is disproportionate. Yes, definitely.
And after that I'll do all the measurements which you have said very correctly, and I think that's it. Rest you guys have discussed almost everything, because you know the examiner, she was asking examiner and she was saying, yeah, everything is okay, everything is okay. If everything is okay, it means there is something which he is missing. So
Yeah.
I think that was the thing which you wanted to guide her, that to do anthropometry.
Yeah, doctor, I have a question, right? Excuse
Yes,
me.
yes.
Like for example, such type of case, if we have to appear like a patient is live, right? This is here it is pictorial form, right? For example, in face-to-face patient, and will that 6 minute is enough to do all the examinations, the Spiegels, anthropometry? So how to process this?
I can answer, Dr. Manna, if you allow me. Okay, so I'm answering this. You know, when we were doing our fellowship exam, our time is even less than this. We get 5 minutes to do everything in that. And believe me, if you have a patient in front of you, then you can do it very easily. But it needs practice, because if you have not done practice, then of course it becomes difficult. But
Yes.
if you have hand-on practice, if you have done this many times on a patient, so anthropometry you can do within less than 1 minute. And rest you are
Yeah,
left with 4 or 5.
Yes, but anthropometry, like this case, it demands like upper segment, lower segment ratio, even arm span as well, right? So it takes
Arm
some.
span is not important here.
No,
Arm
arm
span
span
is
is
not.
not important. Yes, arm span
Yeah,
is important for tall stature, not short stature.
yeah.
For short stature,
What
there
you
are other
do?
maneuvers. Dr. Tahir,
What you do? Yes,
1 minute,
yes,
Dr.
yes.
Tahir, I remind something. For short
Yeah.
stature,
Okay.
there is a few maneuver that is called star fisting. You know, but this child, see the hand is reaching to the mid thigh. If the hand is reaching to the mid thigh, then there is no problem.
Okay.
Okay.
So, ma'am, the diagnosis in this would be vitamin D resistant rickets, hypophosphatemic rickets. How would we prioritize our diagnosis and differential diagnosis?
Sorry, your voice is very low. What is that question? Diagnosis.
Yes, ma'am. Diagnosis and differential diagnosis.
Diagnosis is ricket. Now, ricket, there is varieties of ricket. The first, you have to tell nutritional deficiency ricket, okay? Although there is hair loss, alopecia, but alopecia is also common in nutritional deficiency ricket. Not only vitamin D dependent type 2, because that is very rare. And most common ricket is nutritional deficiency worldwide, okay? Then after nutritional deficiency, you have to say it can be vitamin D dependent type 2 or type 1 or X-linked dominant ricket. But there are other varieties of ricket. There are other varieties of ricket like renal ricket, hepatic ricket. Okay, and I also have some differential in my mind to see the bony deformity. That is, it can be a case of osteogenesis imperfecta or it can be a case of mucopolysaccharidosis. Okay, and most important here, another important point we missed, that is respiratory system examination. Why? Because of this hypotonia, diaphragm does not move. You know, diaphragm is not moving so much. So there is repeated respiratory infection. Okay, so Msk exam, neurological exam, eye exam, ENT examination. Why ENT? Because of the ricket, there is otitis media, bony deformity. There may be otitis media, and osteogenesis imperfecta or mucopolysaccharidosis, they have otitis media. So otitis media, you have to check hearing impairment. You have to check respiratory system, developmental system, abdomen. Abdomen, why? For the hepatosplenomegaly. And also you have to check for hernia, hernial orifice. So Dr. Bella asked me, I want to see the undergarments, but no, actually in the exam it is not allowed. And yes, Dr. Bella did very fast examination, but there is 1 or 2 points that she missed tenderness of the moving. Because, you know, if it is a case of osteogenesis imperfecta, then if you move very fast movement, then what will you do? You will break the bone. So you have to tell the examiner that I want to move the limbs. Okay, am I allowed? Because it can be a case of osteogenesis imperfecta. Then the examiner will say, no, please do not do movement, just do general examination. Okay, so very careful when they gave you musculoskeletal deformity, please very carefully rule out it is case of osteogenesis imperfecta, because you will break the bone during examination, and examination is at all not allowed in osteogenesis imperfecta. They will not give you a case of osteogenesis imperfecta, I'm sure, but if they give, suddenly they can give. Okay, and as I said that this child has many MSK is very big. Okay, let us now discuss. Dr. Tahir, you have any more feedback? I will discuss MSK. You have any more feedback?
I just have one thing to say, and that is because whenever you get such type of a case, it becomes at times very much difficult. So I think keep it simple. What I would do, that first of all, I would take the upper segment lower segment ratio. Okay, if there are features of rickets, I would go with that this is a disproportionate. And by the way, upper segment lower segment will give me that is this a proportionate or disproportionate. Then there are few differentials for disproportionate, like hypothyroidism, like rickets, like skeletal dysplasia, like MPS, like Klippel feel. So these 4 or 5, they are very common, which has come in exam previously in MCPS. So these 4 or 5 I'll keep on the top. Then I will see that the limbs are short or the trunk is short. So if the limbs are short, so what will happen, that the upper segment lower segment ratio will be more than normal. So if it is more than normal, then it will show me that the limbs are short. Okay, but if the upper segment lower segment ratio is less than normal, so it means that the trunk is short. So I will think of MPS and I'll think of Klippel feel.
Okay, yes.
Okay, so this is what mnemonic I have made for myself. Maybe it seems a bit difficult for you, but if you write,
it is the main point. It is the main examination. You have to do upper segment, lower segment ratio. Then you have to tell the examiner that it seems upper segment is shorter than the lower segment because of this scoliosis. So you have to tell this thing. And as one doctor asked that arm span, we do not do arm span, because you know why we don't do arm span? Because it is a short stature. Arm span is important for tall stature. And in the short stature, suppose achondroplasia, there is some maneuver. What are those maneuver? Like, you know, fisting of the hand, star, you know, they touch the hand here, shoulder, touching of the shoulder, so that you can understand there is rhizomelic shortening, there is mesomelic shortening, or there is acromelic shortening. You understand my point? So this fisting of the hand, then star, shaping of the star is for the hypopituitarism or Noonan syndrome, Turner syndrome, because there is short fourth and fifth metacarpal, so star, fisting, and where is reaching the hand, in which level of the thigh, reaching the hand at which level of the shoulder. If it shoot out of the shoulder is shooting out, that means there is shortening of this portion. If there is non-shooting, okay, not reaching to here, then there is shortening of this portion. So you have to understand that which part is short, rhizomelic short, acromelic short, or mesomelic shortening. But here we will not do these maneuvers. Why? Because the child's upper limb seems normal and it reaches to the mid thigh, and there is deformity in the upper limb. Okay, so it is not a case of achondroplasia. It is not a case of hypochondroplasia or hypopituitarism or Turner syndrome. So we will not do this maneuver. And our command is MSK. In MSK command, we cannot follow the protocol for short stretcher. It will be very, very complicated. Okay, because there are other things you have to do, like general examination, frontal bossing, there is widening of the suture, there is large head, box shaped head, there is eye sign, there is teeth sign, there is hearing assessment. So you have to tell the examiner that I like to check the hearing also, developmental assessment, hearing assessment. Okay, and there is hypotonia, so you have to see the Gower sign. There is waddling gait, you have to see the tiptoe gait, you have to see the heel toe walking, you have to do the running. So there are lots of things you have to do. So you cannot do maneuvers for short stretcher in this child. Okay, this is what my comments. Any more? Anyone? Dr. Aparajita, any comments? Yes.
Dr.
Yes.
Tamanna? Sorry.
Yes.
Yes, Dr. Tamanna, what I want to just clarify that lots have been discussed on this topic, that you said the Julian 3-year-old boy having walking difficulty for last 6 months, parents is complaining abnormal gait. Do the general examination and related systemic examination.
No, do
It
the
is
MSK.
your...
I said do the MSK and related general examination.
Okay, related general examination. So in this case, is it okay if I start from after doing the Y parts and 4DS, I'll go for the general examination, like first inspection from the front, from the side, and from the back. So all these features we can pick up rightly. Because if you want, then we go for the piggles, because if the examiner wants, then he can take so many time for the piggles. Like you say, everything is okay, but it may not happen.
No, it will happen, Dr. Aparajita, because in Rickets, there is no tenderness. There is no swelling. There is no fluctuation. Everything is normal.
No, okay. What I'm saying that if we go for the general examination, like first inspection from the front, from the side, from the back, and do then other general examination starting for the hand, then go for the piggles, is it okay?
Yes, it is okay. Yes, it is okay, because you have to do general examination and relevant 4DSP. And in this 4DSP, as we already know that every system is 4DSP. Okay, you will not jump to the piggle. Although the command is piggle, but you will not jump to the piggle. Okay, we will do 4DSP like this. And in that time, you will do the general examination, but your general examination should be focused. Not like, you will not see cyanosis, you will not see palmar erythema, because this is not an abdomen station. You got
because in general examination, we can find the widening of the wrist, widening of the elbow joint. So all these will be prominent, because as from the picture, it is obvious it's a ricket. So why are we going for the piggles? No, means time may lose the time.
You are going for piggles because it is a musculoskeletal station, and musculoskeletal station examination is 2 types. One type is local joint swelling. There is no local joint swelling. Another is piggle. So if you do not do musculoskeletal, if you do not follow the command, then you will do fail, because there is command of MSK. Okay, so you must do piggle because there is no local joint swelling.
Okay, so in that case,
MSK is 2 type of examination. Okay, one is local, another is piggle. You must do this 2 type examination.
Okay, Dr. Tamanna, that in that case, after inspection or doing general, like then doing the gait, then I can go for the piggles?
Yes, of course, of course.
Last 2 minutes. Now, another question is for me, as it is a MSK, should I ask the screening question? Should not I ask the screening question?
Yes, of course. Dr. Bella missed this, because in MSK, you have to ask the screening question. There are 5 screening questions, like, do you have any pain anywhere in the body? She did not ask actually. Number 2 is, do you find difficulty in walking upstairs or downstairs? Number 3, do you find difficulty in shirt, putting on the shirt? This is for shoulder movement. Do you find difficulty in spooning or writing? Because feeding and writing indicate the lower fine motor movement. So you have to ask these 4 or 5 screening questions. Any pain anywhere, upping, or any problem in going up, in going down, any problem in shirt, wearing shirt, any problem in feeding or spoon or writing. This is the screening question you have to ask. And then you will start for DSP. Okay, then you have to start like everything we discussed in our other meeting, that at the beginning you should start and do the general examination and MSK. But you have to remember that general examination will be very focused here, because you should complete it within 1 minute. Because if you do not complete general examination within 1 minute, how can you do PIGAL? PIGAL will take 3 minutes to 4 minutes. And at last you have to tell the examiner that I want to complete my examination by doing upper segment, lower segment ratio. Then I want to do the leg length discrepancy. I want to check the height and weight. I want to check the occipitofrontal circumference and plot it in the growth chart, appropriate chart. And I want to measure blood pressure. I want to see the hernial orifice. I want to do relevant systemic examination like abdominal examination, developmental examination, respiratory system examination. I want to see the hernial orifice. I want to check the eye. There are many systems in this Ricket. I can't say how many systems is involved.
Doctor,
So
doctor.
in the,
Yes, Dr.
Please.
Parajita.
yes, in this
Yes.
case, as there is widening of wrist, the bony deformity is there even in from the PIGAL also. So can from where there we can go for the regional examination for the other joints above and below.
Yes, but there is no local joint swelling. So you will not do any effusion, tenderness, but you will have to say that overall the bony tenderness is present. When I do examination, examiner will say no, there is no bony tenderness. Then you will do the movement. There is no problem, because Dr. Bella finished movement in 1 minute, because I said normal, everything normal. So there is no loss of time for her. Okay.
Dr. Tamanna.
Dr. Tamanna, is there any importance of Beaton score here? Because she did Beaton score and
yes, Beaton score is very important. Beaton score is very important part of musculoskeletal. And also I did touching of the floor. Why? Because it will show you scoliosis is disappear or not. If the scoliosis disappear, it is non-pathological. If the scoliosis does not disappear, it is pathological.
Dr. Tamanna, what is this
Yes.
DSP? I just don't know.
Which one, doctor? Which one? Sorry.
You just mentioned like protocol, not a protocol, sorry. It's-
Oh, 4DSP.
Yeah,
Okay, Dr. Aparajita, tell us what is 4DSP?
yeah.
That is the, here, is there any distress? Is there any device attached? Deformity? Then fourth is the dimension, means height, weight, head circumference. S is the surroundings, and what is P for puberty? If it is
Puberty. But
applicable.
this child we will not do puberty because it is only 3 years.
Okay, got it. Thank you.
So vitamin D deficiency. See, this is
Dr.
Ricket.
Tamanna,
Yes,
sorry.
yes.
Yeah. Like such case in the exam, and we are not able to complete all examination. Like I stuck in between this anthropometry, right? I do all the general examination and I do this general examination, and at the time of the anthropometry, the time gone. Okay, so will this carry negative marks, or is there a different way to carry out this situation?
Okay, as Dr. Tahir said, that in this situation, if you do not measure anthropometry, they may fail you. Upper segment, lower segment, and the leg length discrepancy. And if you don't check the Beaton score is not so important here, only touching the floor. Why? Because this child does not have hypermobile joint. He cannot touch the floor. If he can touch the floor, you suspect there is hypermobile joint, you must do the Beaton score. Okay. And This child may have hypotonia, but actually hypotonia and hypermobile joint is not same. Hypotonia is different thing. Hypermobile joint is different thing. Baton score we don't do for hypotonia. Baton score we do for hypermobile joint. Okay. So for hypotonia, the Gower sign, we are checking the Gower sign because the child has myopathic waddling gait. So we are checking Gower sign here. Okay, it is relevant examination in this child. If you don't do everything, no problem. You just tell the examiner, I want to do this, and this. Examiner will be happy.
Here the Adam forward bending test is relevant. Beaten is not relevant because here seems to be scoliosis. So bend the child, ask him to bend just like we do in prayer. So Adam test, that is important.
Any more questions? So in the Ricket, I asked Dr. Bella, what is the treatment? See the treatment here. Treatment, nutritional Ricket, okay, very important. If the child is under 6 months, we will give 400 international unit daily. This is the active format, drop. Drop is available, okay? Cholecalciferol, 4 drop. If the child is more than 6 months, but less than 1 year, I will give 400. If the child more than 12, 400 is for every child, okay? And less than 6 months, drop. More than 6 months, tablet or drop. More than 12 months, tablet or capsule, okay? So 400 unit per day. How many months? Dr. Bella said 3 months. Okay, so it is actually unless the deficiency is corrected. You have to ensure there is sunlight exposure, proper sunlight. Okay, and you have to ensure the child is taking egg yolk, oily fish, red meat, etc. because they are vitamin rich food. Okay.
But this is only for the prevention, right? This is not the treatment, I guess.
This is for prevention. Very good. Yes, this is for prevention. That's what I am thinking. This is for prevention. Where is the treatment? Treatment is this
Very low
one.
dose.
Yes, treatment is this one. Treatment, you see 0 to 6 months, 3000 international unit for daily for 8 weeks. So we did not tell this to the examiner. So here I will cut down mark. Why? Because the treatment was incomplete. If you give daily, it will 8 weeks, 2 months. If you give single oral, it is 50,000 single. Then after how many days you will check? After 8 weeks, you will check again X-ray, calcium, okay, parathormone. Why? Because you gave single dose. So after 8 weeks, you have to measure and then you have to give again single dose. Okay, because the child may not be corrected in one dose. But if you are giving daily dose 3000, then also after 8 weeks, you have to measure the serum calcium, X-ray, parathyroid, everything. Who did not got this point? Okay, this is very easy. And more than 6 months, 6,000. More than 12 years, 10,000. So the dose should be remembered. And if you give single, it is 1,50,000, it is 3 lakh. Actually, in Bangladesh, we use 1,50,000 for children. STOS, this is called STOS therapy, oral STOS therapy. Okay, we give because, you know, daily they will not take. So we give oral single dose. Sometimes we give intramuscular. If the child has anorexia, we give intramuscular.
This single dose, is it once a week or what?
No, once only. Once only.
Okay.
But after 2 months, you have to check again. So this is the treatment dose, and this is the prevention dose. Prevention dose is 400 for all daily, and treatment dose is different. 3,000, 6,000, 10,000 daily, or 50,000, 1,50,000, 3 lakh once. What is the formula? Formula is vitamin D3, cholecalciferol. Okay. And now the examiner will ask you when you will refer this child. If it is a vitamin D resistant ricket like hypophosphatemic ricket, if it is vitamin D dependent ricket, if there is other secondary ricket like malnutrition, cystic fibrosis, hepatic ricket, renal ricket. Okay. If the child has poor response to treatment or non-adherence of treatment, see 8 weeks. After 8 weeks, you have to measure. If it is below 25 hydroxy level is below 50 nanomole, then you should refer after 8 weeks. See, you should refer. Okay, persistent low phosphate. Low phosphate indicate hypophosphatemic ricket. If there is a sign symptom of hypocalcemia like seizure, developmental delay, irritability, tetany, neurological problem, then you have to refer. So these are the complicated ricket. Now you have to give calcium milk formula every day. Ensure calcium intake daily, at least 500 milligram, and formula milk. Okay, then polycalciferol tablet is available in UK, 400, 1000, 10,000 and 20,000. Okay. See, more than 12 years, you can give 20,000 tablet once every 2 weeks for 8 weeks. Okay, this is important. Monitoring, how will you monitor? Regular monitoring not required. Regular monitoring not required. Okay, so you will monitor at the end of the treatment, mane 8 week. You will check vitamin D level. Is it more than 50 nanomole? You will check, I don't know, X-ray we do or no? X-ray. Here they say vitamin D level. You have to check vitamin D level and give advice, lifestyle modification, sun exposure, oily fish, egg, mushroom, and prevention dose. Very important. Prevention dose for how many months? 6 months. So treatment dose for 2 months, prevention dose for 6 months. Then if recommended nutritional ricket, okay, we will give those, okay, exclusive breastfed infant, no need. If you are giving high dose of vitamin D and the patient is not improved, then it is unlikely vitamin D deficiency. You have to think the other cause. After two months, if the patient is not improved by this much high dose, then you have to think that it is other cause. Remember, alpha calcidiol, that is vitamin D2. Vitamin D2 we do not use. We do not use for treatment. This is the new ricket guideline. Any question from this? Anyone has any comments? We finished ricket.
Problem here is 6 months old, 7 months old child, you are giving the same dose which you are giving to 11 years old or 12 years old child. Right. This is a big discrepancy.
Where daily dose? You are meaning daily dose, right?
Yeah, whatever daily dose, yeah, daily dose you can say.
Yeah,
So this 6 months to 12 years.
6,000 less than 12 years, 6,000.
Yeah, 6,000 to a 1-year-old child and 6,000 to 11-year-old child. Same dose. So
This
vitamin
is it, right.
deficiency. This is too much.
Yeah, too much.
The good thing is the children will have the 6,000 unit per day for 8 weeks.
Yes.
Because all our children will be preferably more than 6 months and less than 12 years.
Earlier, I think it was 6 months to 6 years or 5 years something. Then they had divided 6 years to 12 years
I
like
think
that.
they change it, you know, Dr. Pankaj, because it is blue color. Blue color means they change it.
The previous one was better, I think.
Okay, anyone wants to practice? Dr. Pankaj, you wants to practice this same case, but let's see how you do.
Okay. We can do.
Huh? What?
Give me 2 minutes. I'm
Okay.
having tea, so just 2 minutes.
No, it's okay.
Today, I'm washing
Yes,
my hands and I'm washing my permission. Given. Okay. Okay. So hello, Joanna. Nice. You're a good girl. So what about
Yes,
mentality speech?
Joanna smiling to you.
Okay. Okay. I would like to ask 3 questions. So each not replying anything.
No.
Okay. Then I will ask the mom for 3 questions. She can go upstairs, downstairs, ma'am.
Yeah, she has some difficulty because she cannot go upstairs easily.
Okay. She can dress or undress herself.
Now difficult with this problem.
Okay. And is there any pain or soreness in her body?
Oh, yes, he has some pain. Yes, doctor, he has some pain, but not so much.
Okay. Where it is pain, ma'am? Which part of the body?
Pain when I want to change his nappy or dress, he feels says no hurts.
Okay, pain. Okay. Okay. Thank you. So I'm just giving a smile to Joanna and would like to do inspection. So I'm inspecting around the front, back, and lateral. So I can see the all deformities here. So mom, is it possible that she can walk? What is she sitting there in the couch?
Yeah, she's sitting now. She will walk. Yeah, she can walk.
Okay. Okay, she can walk. So what type of gait she is having?
Myopathic gait, it is waddling.
Okay, so I would like to check her Gower sign. So is it possible for her to do?
Yeah,
While
Gower sign is positive. Yes.
okay, along with that, I was looking at her. So any dysmorphic features were there over the face?
No, no, no.
Okay, what about height, weight, and head circumference?
At heart centile, head circumference more than 90th centile.
Sorry, head circumference more than 90.
90th. Yeah, 90. 90.
90. Okay, and height, weight?
Below third.
Third, sitting height and standing height, I would like to check.
Ratio is 1.3.
Okay, each has brought any devices with her?
No.
Okay, I would do all these things with after removing her shoes.
Yes.
So, yeah, so now I'm checking her back. So is there any kyphoscoliosis there?
Yes, you can see the back.
Okay, so could you please bend down for me? So
Yeah, scoliosis not disappear. She cannot touch the floor.
Okay, scoliosis is present,
Yes.
pathological, right?
Yes.
Okay, that is on the right side.
Yes, you can see.
Okay, right side. Is there any scar anywhere in the body? Scar. Okay, pigmentation marks, bruises, bruising marks.
No.
Okay, thank you. And she is not in distress, right? Comfortable.
No. Yeah.
Okay, I would like to check her from the head. So I can see her head, alopecia is there, box shape is there. I will touch the head. So can I touch the? I will ask the mom. Would you please allow me to touch her head? I will do gently touch.
You can examine. Yeah.
So I'm just touching her head very gently. If there is a estrogen imperfecta, so we'll be careful. So any craniotops is there? Ping pong ball.
No.
Okay, AF.
No.
AF is normal or closed?
Frontally normal. I mean
Okay.
closed.
Okay, very carefully. I would like to check her ears. So is there any infection inside?
No.
Okay, eyes. I would like to check any blue sclera is there.
No, eye normal.
Okay, I would like to check. Could you please open your mouth for me, Joanna?
Yeah, there is dental hypoplasia.
Okay, then any other abnormality in the mouth, like
yes, there is some sore deficiency due to vitamin deficiency. Yes.
okay, so glossitis like picture.
Yes.
Okay, I can see. So I would like to check. Is there any factors of cavity?
4 minutes. Your command is MSK also. Okay.
Okay. The both cannot be done. This is general. Okay, so I would like to check her joint movements. I can see all the abnormalities there. I would like to check her movements of the upper limb. P-galls of upper limb or lower limb you want me to do?
Both.
Both. Okay. On the hands I would like to, but she's saying pain in the lower limb will be difficult. Okay,
Yeah,
upper limb.
he is in pain, so you can do the movement of the upper limb. Yes.
Okay, so I would like to do 3 movements over the shoulder joint. Is there any restriction of
movement on the shoulder and elbow and wrist? Tell me name of the movement.
Okay, I will ask to the shoulder joint 3 movements: flexion, extension, abduction, adduction, and then elbow joint also I will do flexion, extension, and this joint I would like to do this round movement and then flexion, extension. Then I will ask her to do prayer sign, then inverse reverse of the prayer sign, then our thumb touching to all the fingers and the thumb to the index finger.
All are normal.
I would like to squeeze the MP joints.
Normal, no tenderness.
Okay, any other abnormality in the hands? Like
what abnormality do you like to see?
Fourth short this one or clinodactyly type.
No.
Okay.
No deformity.
I'm doing all these things by letter. Now I have asked to raise her head and to the sky and what the hands up. Is it possible?
Normal. Spine movement normal.
Okay, so back she's back hand and then both the hands back side all normal.
Normal.
Okay, you want me to check lower limb now?
No, time is up. So what relevant examination you want to do for this child?
Yeah, I would like to check her cardiovascular examination and blood pressure check.
Yes.
Okay. So yeah,
Okay, then.
then full developmental examination and
Okay.
liver and spleen abdominal examination and tone I will check.
Okay.
I put
Okay.
on your
Then
tone. Yeah. So today I have examined Jonah, 3 years old. She has difficulty in going upstairs, downstairs, and she is comfortable at rest. She is short for her age. She is third centile and head circumference is 90th centile. I would like to plot her on appropriate growth chart. On examination, I found that there is a Wedling gait. Someone is putting in the box. On examination, there is a Wedling gait and cover sign present. And on abnormalities, I found that there is a frontal head is bossing of frontal leg, alopecia is there, and then she is having this Harrison sulcus, and this wrist joint is swollen wrist joint, especially on the right side, and right leg is deformed. Bowing of the legs are present. So I would like to complete my exam with the blood pressure and cardiovascular examination, along with abdominal examination for viscoptosis. So my most important diagnosis in this case is rickets, type 2 rickets. Second differential is osteogenesis imperfecta. Third, it can be mucopolysaccharidosis or metabolic disorders, because she could not talk to me. So that is my third diagnosis.
Okay. So Dr. Pankaj, you tell me that this kind of scenario comes in exam like Pigal with general examination for Ricket, or they will give you like only lower limb Pigal?
No, this is will be others.
Others
If it is definitely they will give in others. If it is rickets, ricketic signs are there. And if it is not rickets, then they will give MSK. In MSK, definitely they will give us joint swelling is there like JIA, or maybe rashes over the body like SLE or dermatomyositis type picture, or maybe HSP. So that will be in the muscular means muscles and bones. But here purely bones are involved. Right here, I can see that there is a scapula is, so maybe 11th nerve paralysis, but not, this is not a CNS case. So otherwise, you can see right side spinal accessory muscle may be paralyzed, because usually help.
Hey, Dr. Pankaj, open your mic, please. I muted all.
Okay, sorry, thank you. So you can see scapula is not, an angle of the scapula is not good on the right side, because
Yeah,
there may
right.
be a deformity involved. So this is not a clepal fill, because there is no short neck, no lower hairline. But you see that his right shoulder is just like you can say different than the line.
I can, in Ricket, there is generalized, this child has generalized right-sided deformity. I think
Blount's, then the Blount's disease, you can suspect the Blount's disease, because her right leg is affected more than the left leg. So you can think of Blount's. If you see this picture, second picture, then Blount's disease can be one of the differential. But if you see the first picture, then Blount's disease is not
from
there.
the Ricket website, okay? I took it from the Ricket website. So diagnosis is confirmed. It is Ricket baby, okay?
So differential.
Yes, but this scapula, actually, there is some deformity. And I think as the baby develop, severe Ricket, so the whole body bone can be deformed. Whole body. They see there is spine also involved. So this baby is actually severe form of Ricket, okay?
Yes.
Okay.
Dr. Tamanna,
Yes.
yeah, I doubt these two pictures, are they of the same child?
Yes, same child. I took it from the same website, but maybe in the website they gave two different child. I took it from the same website. Yeah, maybe. Because you can see that this child is little bit dark complexion, right? And this is very fair complexion. And this child has shoe. She doesn't have shoe.
Yes.
Yes.
Because this tibia, both this is grossly deformed, right? As compared to this.
Yeah.
Yes, it is difficult to say that it is both of the same child. Yes. How to comment on this one? This
yeah, but
first
it is
child
Ricket,
with this.
definitely. Definitely Ricket is the diagnosis, because I took it from the Ricket website, okay?
Okay. So
Yes,
here,
any
how
question?
to comment this lower limb like this? Lower limb where this foot, this is flat foot and there is this gap also. So how to comment this or this
Yes, in this child,
tibia and the
suppose in
foot?
this child, you will measure here from the tibial epicondyle, tibial tuberosity to tibial tuberosity. And these two distance, tibial tuberosity, no, actually it is epicondylar. So I think condyle of the
Intercondylar distance.
intercondylar distance
Intercondylar distance.
more than 7 centimeter is abnormal. Here, if you measure, yes,
Okay, go on.
if you measure from the intercondylar distance, it will be more than 7. Okay, and here you see here the intermallular distance is not more than 7, it is less than 5 centimeter, less than 5. See, they are touching each other. This is intermallular distance. We see this thing. If there is genu varus deformity, this is genu vara, right? Genu vara. If there is genu varus deformity, then the intercondylar distance will be increased. But if there is knock knee, what is knock knee? Genu valgus deformity, knock knee. If there is knock knee, like this patient has knock knee.
This first child is knock knee.
Knock knee. In that patient, you will get
Yes.
intermallular distance more than 7 centimeters. See here, intermallular distance more than 7. So genu varus and genu valgus, these are two different. In genu varus deformity, the intercondylar distance will be more than 7. In genu valgus deformity, intermallular distance will be more than 7. Am I correct, Dr. Pankaj?
Yeah, correct. But I want to point out one important thing. People were discussing that we should do sitting height and standing height. This is not required in this case because you were discussing. So I had done. Ideally, that is done in short stature. So just to find out whether it is proportional or disproportional short stature. In that case, we do sitting and standing height. But here it is others, so they are not required because from the
I was
picture.
wondering same, right? The time will be very
From the
short.
picture, it is clear that this is proportional. In Rickets, it is a proportional short stature.
Yes, you're right.
Hello.
Yes, you're right. This is not a case of short stature case. Actually, this is a case of Ricket, and it will come as a general examination. But they can give you as MSK also. But if they give you MSK, you should be doing very limited MSK. Okay, MSK, there is two types of examination. One is local, another is Spiegel. This child has no local swelling. See, there is no local joint swelling. This is not a joint swelling. This is called widening. There is a difference between swelling and widening. Widening due to Ricket and swelling due to JIA. So this is two different things. This child has mild tenderness, as I said, because of the Ricket, not because of the JIA. It is not a case of JIA. So JIA MSK examination and Ricket MSK examination is different. Ricket, you will do mainly targeted general examination, plus you have to do the height, weight, OFC, very, very important. And sitting height, standing height is important if there is scoliosis. See, this child can have upper segment short than the lower segment. So it will be disproportionate short stature. As Dr. Pankaj said, Ricket is proportionate. Actually, Ricket can be disproportionate also if there is severe scoliosis or severe lower leg deformity or both.
So that is secondary to the bony, to deformities in the body. So that's why they will not give you the short stature in Rickets, right?
Yes.
Both will not give you. They will check the short stature and check the Rickets also.
Yes.
So short, there's a disproportion maybe because of deformity, not as a like epiphyseal fusion or like that. It is not
Very
fused.
good. Like not in achondroplasia. Like in achondroplasia, there is epiphyseal close, epiphyseal shortening. So this is not like that. This is due to deformity. There is disproportionate. Can be happen. Okay, so in the command, I hope in the exam they will give you only general this Ricket, because if they give you Ricket MSK, then it is very tough. Okay, but achondroplasia MSK is very easy. Achondroplasia MSK, we will do another day. Achondroplasia, okay, not today. Okay, then everyone, I
So-
like to stop
so-
it. Yes,
so
any
the-
question before we
Yeah,
go, Dr.
yeah.
Puri?
So-
Yeah.
For example, in a live face-to-face patient, right? So do they give this height and weight, everything, or during that 6-minute time, we have to take the height and weight of a child?
No, you can't. You can't. 6 minutes will go by height and weight. So you have to, they will give you the height and weight.
Yes.
Sometimes they will give you the plot. They will tell you, plot it in the chart. So that you have to do sometime.
So we have to ask for them. So what is the height and right?
Yes, what is the height? And I like to plot it in the chart.
Okay, thank you.
Any more question? Okay, then I will take goodbye now. See you in the next session, inshallah. Dr. Pankaj, thank you very much. Dr. Aparajita.
Thank you.